Welcome to week 2. Week 2 we are going to be talking about CVA, brain anatomy, and specific syndromes. We are going to be looking at clinical deficits that we would expect to see according to where in the brain the injury has occurred. All of this information comes from a continuing education course that I took from the Rehab Institute of Chicago. Therefore, there is no textbook or chapter to read. That is why this PowerPoint will have voiceover for each slide. In case you have questions or concerns, hopefully I will be able to address those with the voiceover PowerPoints. Alright, let's jump right into it. I have a picture here of the brain showing these different lobes. The brain anatomy specifically, you've got the frontal lobe, parietal lobe, temporal lobe, and occipital lobe. The frontal lobe is responsible for motor activity, parietal lobe responsible for mainly sensory functions, the temporal lobe again responsible for memory and hearing, occipital lobe responsible for vision and balance. Also located in this picture is the thalamus, extreme upper end of the brainstem. This routes many pathways that connect the brain with the brainstem and the spinal cord. You have the brainstem itself, upward extension of the spinal cord. This is primarily responsible for breathing, heart rate, blood pressure, face, mouth, throat, sleep, wakefulness. So if you had a stroke in the brainstem, unfortunately, the prognosis is not very good. Corpus callosum, large mass of fibers that binds the two halves of the brain together. Diving further into cerebral vascular anatomy, the common carotid arteries have two divisions. The external carotid arteries supply the face and scalp with blood. The internal carotid artery supplies blood to the anterior 3/5 of the cerebrum, or 80% of the blood supply. The internal carotid arteries arise in the anterior portion of the neck and enter the cranial cavity through the carotid canals in the temporal bones. The terminal branches are the anterior and middle cerebral arteries. And you will recall from Neuro 1 that the most common site of a stroke is the middle cerebral artery. Alright, moving on, the vertebral arteries supply the posterior 2/5 of the cerebrum, part of the cerebellum and brainstem, or 20% of the blood supply to the brain. The vertebral arteries begin in the root of the neck as the first branch of the subclavian arteries. At the junction of the medulla and the pons, the vertebral arteries unite to form the basilar artery. This is just a great diagram depicting all of those structures, the arteries, specifically how that blood flow then is routed through the brain and how it's supplying nutrients and oxygen to specific areas of the brain. So now let's do a little quiz. You've got a picture here with 9 different points in arterial blood flow in the brain. The next slide gives you the answers, so please don't cheat and go ahead. What I'd like you to do is take out a piece of paper, number it 1 through 9, and see if you can name these structures. The next slide will give you the answers. Alright, let's jump in with our first syndrome that we're going to talk about in this lecture. It's the anterior circulation syndromes. Anterior cerebral artery, which supplies the interhemispheric cortical surface of the frontal and parietal lobes. So let's go back and look at our previous slide of what the frontal and parietal lobes are responsible for. And you should recall from that the frontal lobe is responsible for motor functions, parietal lobe is responsible for sensory functions. So if we have a syndrome or an injury involving anterior cerebral artery, which supplies those areas, we can expect to see motor and or sensory deficits in our clients. So specifically with anterior circulation syndrome, specifically the anterior cerebral artery, the motor impairments we would see contralateral distal limb hemiplegia because of ischemia over the paracentral lobule, which provides motor and sensory control of the legs. We'll also see shoulder involvement in large strokes with some sparing of the forearm, hand, and face. We'll also see foot drop. It can be a long-term impairment, and we will also see some type of forced hand grasping. So continuing on with an anterior cerebral artery infarct or deficit or syndrome, we would also expect to see apraxia. With either right or left stroke, there is going to be a left limb apraxia, and this is actually because of the corpus callosum being affected and therefore no communication between both hemispheres. We would also expect to see agraphia. That's the disturbance in writing intelligible words. We would also expect to see tactile anomia, which is the inability to name objects by touch. We see all of this because of an infarct to the anterior corpus callosum, resulting again in that disconnection between the left language areas and the right motor cortex, which controls the limbs. From a sensory standpoint, with an anterior cerebral artery deficit, injury, infarct, we would see sensory loss of the contralateral leg, worse distally. We would see loss of two-point discrimination, loss of joint position sense. We would also see loss of stereognosis. Again, this is the ability to tell what an object is by touch. And then sharp testing is often reported as slightly dull. So again, we might notice some impairments here, but again, still should be able to feel a little bit. From a language standpoint, we would see impairment in motivation and initiation, which is termed abulia. We would also see transcortical motor aphasia, which is called non-fluent aphasia with stuttering. Continuing on with anterior circulation syndromes, let's specifically talk about middle cerebral artery injuries. Again, middle cerebral artery being the most common site of strokes, the middle cerebral artery will supply a major portion of the lateral cerebral hemisphere. It is the largest branch of the internal carotid artery. It does have many branches. This is good because the more branches you have minimizes the actual physical deficits your clients should experience. The middle cerebral artery continued. The upper division of the MCA supplies the frontal lobe and the parietal lobe. You will typically see perceptual deficits because of that parietal lobe involvement. You will also expect to see motor. The lower division of the MCA supplies the temporal, lateral, occipital, and the posterior half of the parietal lobe. Again, you would expect to see visual deficits because of that occipital involvement. If the injury in the middle cerebral artery is in fact in that main stem, you have a main stem infarct or a main stem stroke, you would expect to see contralateral hemiplegia. You would see deviation of the head and eyes toward the lesion, which would be away from the hemiplegia. You would see contralateral hemianesthesia, which is loss of sensation on one side of the body. You would also see contralateral hemianopsia, which is loss of half of a field of vision. You would expect to see dysphagia and an uninhibited neurogenic bladder. Okay, here's where it can get confusing, so please hang with me, and that's why I'm doing the voiceover PowerPoint. Continuing on with the middle cerebral artery main stem infarct, the Rehab Institute of Chicago has now termed dominant versus non-dominant, which is what we would typically think of as left brain and right brain. So I am still going to refer to it as left brain, but know that the current terminology is there in parentheses as dominant. So if you're having this main stem infarct in your left brain, which we are considering the dominant brain, you would expect to see in your client global aphasia and apraxia. If that middle cerebral artery main stem infarct is in the right brain, which is considered non-dominant, you would expect to see hemi-inattention or hemi-neglects. You would see anosognosia, which is a severe form of neglect, visual perceptual deficits, such as dressing apraxia or constructional apraxia. You would also see aprosody, can never say that, bear with me, impaired ability to use normal pitch, stress, and rhythm of speech. You would also expect to see affective agnosia, which is facial or auditory disturbed recognition. Okay, continuing on, if you have an infarct in the upper division of the middle cerebral artery, we would expect to see frontal and parietal involvement. Therefore, deficit-wise in our clients, we would see contralateral hemiplegia. The face and the arm would be greater than the leg. We would also expect to see contralateral hemianesthesia, deviation of the head and eyes toward the lesion away from the hemiplegia. Again, this may or may not be present. The same with contralateral hemianopsia. We may or may not see this. Okay, continuing on with that upper division infarct in the middle cerebral artery. It would be very similar to what you would see in a main stem infarct, but the hemiplegia and the language comprehension deficits are not as severe, which is good. Motor strength and control are better in the lower limb than in the hand and the face. Okay, so again, hang with me because again, according to the Rehab Institute of Chicago, we should be terming this dominant side what we would consider left brain CVAs. In the upper division of the middle cerebral artery, we would expect to see Broca's aphasia. Frequently speak in short phrases that make sense but are produced with great effort. So these patients often omit small words such as is, and the. For example, a person with Broca's aphasia may say walk dog, meaning I will take the dog for a walk, or book to table for there are 2 books on the table. So people with Broca's aphasia typically understand the speech of others fairly well. We would also, with the left brain dominant side, expect to see ideomotor apraxia, and this is the inability to translate an idea into actual motion. So they know what they're supposed to do, they're just unable to actually physically do it for you. Okay, so we just talked about upper division middle cerebral artery infarcts for left brain or dominant side. Let's talk about right brain or non-dominant side. Deficits that we would expect to see in our clients are hemi-inattention or hemi-neglects, visual perceptual deficits, and aprosity. Yes, that is the correct way to say it, aprosity. Please watch these videos giving different examples of different types of aphasia that you would see with both dominant and non-dominant side strokes. Okay, we've discussed stroke in the upper division middle cerebral artery. Let's move on now to the lower division. You could see that in the temporal, parietal, or occipital lobes. This is less common than an upper division stroke, and typically this would be caused by an embolic event. Motor function is generally intact, which is good. Rare is hemisensory loss, and typically what we would see is a contralateral hemianopsia. Continuing on with that lower division infarct in the middle cerebral artery, again in the left brain, which we would consider the dominant side, we would see Wernicke's aphasia. And people with Wernicke's aphasia typically speak in long sentences that have absolutely no meaning. They add unnecessary words. They will even create made-up words. For example, somebody with Wernicke's aphasia may say something like, you know that Smoodle Pinkard and that I wanted to get him around and take care of him like you want before. As a result, it is often difficult to follow what the person is trying to say. People with Wernicke's aphasia usually have great difficulty understanding speech, and they're often unaware of their own mistakes in speech. On the right side, non-dominant side, lower division infarct with middle cerebral artery, we would see affective agnosia and hemi-inattention or hemi-neglects. Please watch the following video of somebody who suffers from Wernicke's aphasia. Okay, so we just concluded anterior circulation syndromes. Let's move on to posterior circulation syndromes. This picture here is a great illustration of blood flow, arterial blood flow to the anterior cerebral artery, the middle cerebral artery, and posterior cerebral artery. So in the posterior circulation syndromes, we're specifically going to be looking at that posterior cerebral artery, which as you can see supplies the midbrain. With an infarct or injury to the posterior cerebral artery, we would expect to see sensory loss. Hypoesthesia, which is rare, would be partial loss of sensation. Dysesthesias with tingling. This is an unpleasant or abnormal sensation in the affected side. Occasionally you would have hyperesthesia or pain and feelings of heaviness on the contralateral side. With an infarct in that posterior cerebral artery, we would also expect to see visual deficits. The first one, dyschromatopsia, which is an altered color discrimination because of damage to the visual association area. We could also see incomplete cortical blindness, alexia without agraphia, can write but they can't read. We might see a right visual field deficit, There will be a disconnection of that right visual cortex from the primary language area of that left hemisphere, and we could also see visual agnosia. We can also see cognitive deficits with the stroke in that posterior cerebral artery. Typically what we would see here is impaired memory. That could be both short-term or long-term memory. Okay, moving on, we have lacunar strokes. Lacunar strokes are located deep within the cerebral white matter, basal ganglia, thalamus, pons, and result from an occlusion of single small vessels. So a patient with a lacunar stroke might not even realize that they've had a stroke. Typically it takes multiple lacunar strokes even before you would see deficits or they end up in the hospital. I actually had one patient who had a lacunar stroke, and by the time he even realized it on CT scan and on the MRI, it was upwards of, I think, 7 or 8 lacunar strokes that he had suffered before he even realized that there was anything wrong. Typically, lacunar strokes are common in patients who have a history of hypertension or diabetes. When you see deficits with lacunar strokes, you would see pure motor hemiplegia, which would affect the face and the arms. Typically, they have normal sensation, normal cranial nerves. The infarct can occur in the corona radiata, posterior limb of the internal capsule, the pons, or the medullary pyramid. So again, you need to have multiple lacunar strokes before you typically would see deficits. Deficits again that you might see would be ataxic hemiparesis, and again this would be varying depending on the number of strokes that this patient has sustained. Typically you would see that weakness in the leg, greater weaknesses in the foot and the ankle. Arm is not weak, but it can be very ataxic, so a lot of coordination tasks would be very appropriate with the upper extremities for a client who has sustained lacunar strokes. Again, the infarct can occur in the anterior limb of the internal capsule, the corona radiata, or the rostral pons and peduncles. Again, depending on where that infarct occurs in lacunar strokes, dysarthria or a clumsy hand could be present. The upper extremity with uncoordinated movements. So again, you're looking at a lot of fine motor coordination activities. Face and arm might be weak. You might see some dysarthria, some dysphagia, which is weakness of the muscles used in swallowing. So speech therapy is most likely going to be involved as well. And these infarcts would be happening in the anterior limb of the internal capsule or the pons. When that lacunar stroke happens in the ventral posterior thalamus, you would typically see pure sensory deficits. That could be partial or complete sensory loss of the face, arm, trunk, and leg. And it stops exactly midline. It's absolutely crazy to see clinically, but it does stop midline. Some report increased or unusual sensations. Sometimes it's painful, sometimes it's hypersensitivity. Again, that infarct occurs in the ventral posterior thalamus, and you would see pure sensory deficits. If that lacunar stroke is happening in the border of the ventral posterior thalamus or the internal capsule, you can have sensory motor hemiplegia, sensory and hemiparesis, or hemiplegia that affects the face, arm, and leg equally. And again, that infarct occurs in that ventral posterior thalamus or the internal capsule, and again, it's typically sensory motor hemiplegia. To conclude this lecture, we're going to finish with vertebrobasilar syndromes, and this picture here is a good depiction to give you an idea of, again, that arterial flow. You have vertebral arteries that branch from the left and the right, subclavian arteries. They eventually unite to form that basilar artery, so you can have different infarcts or strokes in the area that would cause a number of different vertebrobasilar syndromes, and we'll get into those now. The first vertebrobasilar syndrome that we'll talk about is Weber syndrome. It's an infarct to the base of the midbrain, ipsilateral third nerve palsy, which will cause ptosis, which is essentially just that eyelid drooping. You'll have loss of an upgaze and adduction of the eyes. You can also see contralateral hemiplegia. The second vertebrobasilar syndrome that we'll talk about is Wallenberg syndrome. Typically the infarct is going to be in that lateral medulla. You would see ipsilateral limb ataxia, ipsilateral loss of pain and temperature sensation in the face, contralateral loss of pain and temperature sensation in the body. You can also see dysphagia and dysphonia, which is an impairment of that voice. Typically it sounds very hoarse and kind of even ragged. Continuing with symptoms that you would see with a Wallenberg syndrome would be ipsilateral Horner's syndrome, meiosis, ptosis, decreased sweating of the face, neck, and axilla area, lateral pulsion toward the side of the lesion, so essentially what we call Pusher's syndrome. You can see vertigo and nystagmus. And finally, last but not least, locked-in syndrome is also a vertebrobasilar syndrome. This typically affects younger populations. Symptoms that you would see in these clients are bilateral hemiplegia, bilateral cranial nerve palsy. Essentially, these patients look like a spinal cord injury tetraplegic patient. Upward gaze is spared, but unfortunately not a whole lot of function. This concludes the CVA lecture on brain anatomy, structures, and function. This is the reference, again, a continuing education course that I attended at the Rehab Institute of Chicago. Hope you enjoyed it.